Hello, my name is Dr. Monica Flores, and I'm a pediatrician in South Florida, and I've been in practice since 2001. In my first two coding videos, I reviewed the changes in time and in medical decision-making that were made by the AMA for the outpatient setting. In this series, I present real patient encounters and how I would build them in light of the new guidelines. Please keep in mind that these guidelines are still in transition, and if any changes have been made since the publication of this video, I will update those in the description. Also, please comment with any questions or requests for clarification. Only through educating each other can we master these changes and optimize our billing. These cases are presenting from a practicing physician standpoint. I am not a coder, but I have an interest in coding since residency when my notes were torn apart by both my attending and the certified coder that worked in-house at the Mayo Clinic. Since then, I've attended workshops, conferences, and read every publication that I could find on coding. I've been through several audits, and with the help of a certified coder, I've come ahead. The first case is a telemedicine visit for lab results. This is a disclaimer that we put in front of every visit. I would say that since COVID, my visits have been about 50 to 80% telemedicine. The first thing that I do before even opening the chart is that I note the time. And once I open the chart, I put that time right next to the chief complaint. It's very important that we start keeping track of time during all of our encounters. Just find a method that works for you. I usually prefer to have a patient present, especially teenagers, when I'm talking about changing lifestyle. It empowers their teen in making decisions for their own health. In this visit, Mom had opted to send the child to school because she was developmentally delayed, and I understood. We no longer have to worry if the patient is not present for the visit. The 2021 guidelines actually work in our benefit during visits without the patient present. Coding by time doesn't require the presence of a patient, only your total time. Time spent reviewing the chart, talking to the patient, documenting, or speaking to another provider. All this time must be done on the same day. And this time can only be provider time, not staff time. So if your MA or nurse takes the history, that time does not count. There are different codes for established patients and new patients when coding by time. When coding by medical decision-making, the presence of a patient is also not necessary. The guidelines have gone as far as removing history, review a system, past medical social history, and exam from coding by medical decision-making. When we choose a code, we just have to choose the code that gives us the highest level of service for what is documented in your note, either by time or medical decision-making. One or the other, you do not, I repeat, you do not have to meet the criteria for both. In this case, it took me 9 minutes to update the history and ask if any other problems needed to be addressed. I also reviewed the lab results. I talked about the importance of vitamin D, explained normal and optimal levels. I talked about sources of vitamin D, the importance of vitamin D supplementation. I took the time to show the caregiver actual brands of vitamins, and I had the caregiver take screenshots, or if it's a live visit, I have them take pictures. I keep those pictures saved on my computer, so it's quick and easy for me to access them during the visit. To make things faster and easier for myself, I have my common plans as pre-clicks in my EMR, and they're backed up as Word documents, which I then modify, cut and paste, and email via our secure portal to our patients so they can share with other caregivers in their home. Last but most importantly, I note the time and close a note. Again, in coding by time, we use total time, chart review, patient encounter, documentation, communication time with other providers, and anything done by the provider that same day. In this case, I spent 1 minute prior to the patient picking up reviewing my chart, 9 minutes face-to-face with the mom, and another 8 minutes after the mom hung up, documenting the chart and sending her the secure email. By the time I finished the chart, I had spent a total of 18 minutes, which unfortunately was 2 minutes below the 99213 criteria. So now let's see what code we can meet in medical decision-making. Remember, we only need to meet the criteria for either time or medical decision-making. In medical decision-making, we need to meet the criteria in 2 out of the 3 categories, either problems, data, or risk. Now, if we look at 99213, we definitely meet the criteria for data because the 2021 guidelines, if you have an independent historian other than the patient, then you could meet the criteria for data. And in this case, my historian was Mom. I did not need the patient. When meeting the criteria for data, we meet one or the other. You don't have to meet both. Remember, document with whom you are communicating and plan as well in chief complaint, especially when you're talking about teenagers. An auditor may assume that a teenager can take care of their own health, and we all know that that is not true. The caregiver, usually mom, is always having some input. That is why I usually try to document discussion with mom and questions addressed mostly from mom. Now, out of curiosity, could we have met the criteria for 99214 since we were reviewing labs? And that is a resounding no. Remember, you get data points for only reviewing unique labs. With the new guidelines, if you ordered the labs, you only get data points when you order and not when you review. Unique labs would be labs ordered by an outside provider. If you're reviewing the vitamin D level ordered by the endocrinologist, then that would count as a unique lab. Since I met the criteria for 99213 in data, can I meet it in problems or risk? In problems, things get a little bit hazy. Is vitamin D deficiency a self-limited minor problem, or is it an acute uncomplicated illness? In this case, I'm going to make a case that vitamin D deficiency is an acute uncomplicated illness due to the fact that I'm treating the condition. I'm prescribing vitamin D, even though it's over the counter. I explained the dosing and we'll be rechecking the levels in 2 to 3 months. Since you met the criteria for 99213 in problem and data, you could stop there. But out of curiosity, let's check and see if we can meet it in risk. And we do, because we recommended an over-the-counter treatment. That is one reason why, even when sending over-the-counter medications, I send them through my EMR. Just warn patients that these medicines are considered over-the-counter and they may not be covered, and they will need to purchase the over-the-counter brands that I recommended. As you get faster, you may document this note in less time, but you won't have to worry because you will still have a 99213 for talking to a patient about vitamin D deficiency.